Welcome to the deep dive.
Yeah.
Imagine you're stepping into a specialist's office.
Right.
You sit down on that crinkly paper, and the doctor hands you a genuinely impossible choice.
It's a brutal position to be in.
It really is. On one hand, you can undergo a procedure to finally treat this chronic, debilitating pain that has just been hijacking your life for years.
Yeah.
But on the other hand, that exact same surgical procedure might permanently, irreversibly damage your ability to ever have a biological child.
It's just a staggering ultimatum to face. And unfortunately, for millions of women worldwide who are dealing with severe endometriosis, I mean, it's not some far-off hypothetical scenario, you know?
Right.
Or a rare edge case. It's just the standard reality of their medical care. They are routinely asked to weigh their current quality of life against their future family planning.
Which is exactly why we're doing this deep dive today. We are looking at a fascinating 2023 study published in the Journal of Minimally Invasive Gynecology.
Yeah, and this has backing from the AGL, which is
The premier global association for minimally invasive gynecologic surgery, right?
Exactly. And the research we're focusing on comes from Dr. Adrian Crestani and his colleagues at the Franco-European Multidisciplinary Endometriosis Institute.
And they operate out of a clinic in Bordeaux, France, right?
Yes. They're a highly specialized team, and they are tackling this exact medical dilemma head-on. Their mission with this study was to evaluate a surgical technique that sounds almost like something out of a sci-fi novel.
Totally.
They want to see if this technique can successfully treat severe ovarian cysts while actually protecting the patient's reproductive future.
And the technique is called laparoscopic sclerotherapy. So we're going to find out if this is like the ultimate medical hack for endometriosis patients.
Right.
Okay, let's unpack this, because before we can understand why this new French protocol might be revolutionary, we really have to understand why the current standard treatment is so incredibly flawed.
Yeah, we have to look at what's actually going wrong in the operating room right now.
Exactly. So what is the main issue?
Well, to understand the flaw, we really have to look closely at the enemy here, which is the endometrioma.
Okay.
For patients with a condition called deep infiltrative endometriosis, the tissue that normally lines the inside of the uterus essentially goes rogue.
Right, grows outside the uterus.
Exactly. It invades other organs in the pelvic cavity, and when this rogue tissue takes root on the ovaries, it can form an endometrioma.
So think of it as a dark, fluid-filled ovarian cyst.
Yes, and it is entirely lined with that invasive endometriosis tissue, all surrounded by a really thick fibrous capsule.
And these aren't just, tiny microscopic nuisances, right?
Oh, not at all. Up to 20% of patients with endometriosis will develop these specific types of cysts, and they can grow to be massive.
Wow.
The patients in the Bordeaux study, they all had cysts larger than 40 millimeters.
That's over 1.5 inches in diameter.
Right, sitting right there on a very delicate reproductive organ.
So you have this painful, actively growing toxic cyst on an ovary. The traditional medical response is a procedure called a cystectomy, right?
Yeah, the surgeon goes in, opens things up, and simply cuts the cyst out.
But from what I understand reading the background on this, the physical act of cutting is where the major problem starts.
It's the root of the entire dilemma, and it really comes down to the microscopic anatomy of the ovary itself.
How so?
Well, in a perfect, easy scenario, a surgeon could just pop the cyst out of the ovary like you'd, pop a pit out of a peach.
The pick comes out clean, the peach stays intact.
Exactly. But with an endometrioma, there is no what we call a cleavage plane between the wall of the cyst and the healthy outer layer of the ovary.
And that outer layer is known as the ovarian cortex.
Right. Because of the inflammatory nature of the disease, the cyst and the healthy cortex are functionally fused together.
So it's less like removing a smooth peach pit and much more like trying to peel a fused sticker off a really delicate paper canvas.
That's a great way to visualize it.
You literally cannot rip the sticker away without tearing some of the paper underneath it.
Yes. When surgeons cut the cyst out, they inevitably take healthy ovarian tissue with it. There's just no surgical blade sharp enough or hand steady enough to separate fused tissue without collateral damage.
That makes sense.
And the larger the cyst, the more healthy tissue gets dragged out with it. But the physical cutting and dragging isn't even the worst part of the damage.
Wait, really? What's worse?
Well, when you cut human tissue, it bleeds. And ovaries have a very rich blood supply. So to stop the bleeding, the surgeon has to use a technique called coagulation.
Meaning they essentially apply intense heat or like electrical current, to burn the blood vessels shut.
Yes, they're cauterizing the wound, and that ovarian cortex you are burning to stop the bleeding.
Yeah.
That thin outer layer of the ovar is exactly where the primordial follicles live. That is the patient's entire ovarian reserve.
Oh, wow.
And the decline of the ovarian reserve is a continuous one-way street. Once those microscopic, immature eggs are physically removed or damaged by heat, they do not ever come back.
So the cystectomy physically tears away some of the reserve, and then the subsequent burning destroys even more of it.
Exactly.
Okay, so this brings up a massive contradiction that I think anyone listening would spot immediately. We measure a woman's ovarian reserve using a biological blood marker called AMH, right?
Anti-müllerian hormone, yes.
Right. And higher AMH generally means a higher reserve of eggs.
Correct.
So if cutting out the cyst is medically proven to severely lower a patient's AMH and permanently damage their ovarian reserve, why do doctors do it at all?
It's a fair question.
I mean, if a patient comes in saying they want to have a baby in 2 years, why not just leave the cyst alone and preserve the eggs?
Because the cyst itself is actively hostile to fertility. You often just don't have a choice.
How so?
These cysts are part of that larger, deep, infiltrative endometriosis disease process. They cause agonizing pelvic pain that ruins daily life. They can rupture, which is a medical emergency.
Right, of course.
They can weigh down the ovary and cause it to twist on itself, cutting off its own blood supply. And ironically, the highly inflammatory toxic environment created by the fluid inside the cyst can actively prevent a patient from getting pregnant anyway.
Oh, so leaving it isn't really an option either.
No. Sometimes you even have to remove the cyst just to allow IVF treatments to work. The cyst might literally be physically blocking the doctor's needle from accessing the healthy eggs for retrieval.
So you're completely trapped. If you leave the sticker on the canvas, the toxic sticker slowly rots the canvas anyway.
Yeah.
But if you rip the sticker off, you tear the canvas yourself.
Exactly. Which brings us to the actual intervention that Dr. Crestani and his team in Bordeaux are testing, which is chemical destruction instead of physical removal.
Right, because if pulling the sticker off tears the paper, what if we could just chemically dissolve the sticker while leaving the paper completely intact?
That's the foundational logic behind laparoscopic sclerotherapy. The surgical goal completely shifts. Instead of trying to remove the capsule, the goal is to leave the structure in place to preserve the delicate ovarian cortex, but chemically destroy only the rogue endometrial tissue lining the inside of the cyst.
So it stops causing pain and can't grow back.
Precisely.
I need you to walk us through what this actually looks like in the operating room. Because when I was reading the methodology section of this study, it sounded less like a standard surgery and more like a high-stakes bomb defusal.
It really does require an unbelievable level of precision and patience. Keep in mind, the surgeons in this specific study each had over 10 years of experience in complex endometriosis surgery.
Wow. Okay.
The very first rule of this sclerotherapy procedure is absolute immobility. They do not dissect the cyst or try to free it from the surrounding scar tissue and adhesions. They want it locked perfectly in place.
Wait, why is immobility so important?
Because they are about to puncture it,
Yeah.
and they absolutely cannot risk the contents of the cyst spilling into the patient's wider pelvic cavity.
Yeah, because of that toxic fluid.
Yeah, the fluid inside an endometrioma is often called chocolate fluid. It's old, degraded blood and highly inflammatory cytokines. Spilling it can cause massive irritation and literally spread the disease.
Wow. Okay, so they want it immobilized.
Right. Operating through tiny incisions using laparoscopic cameras and tools, the surgeon carefully punctures a tiny 5-millimeter hole directly into the wall of the cyst.
Just a tiny hole.
Yeah, and through that hole, they insert a specialized suction and irrigation system. They begin washing the inside of the cyst with a clear saline solution, and they just keep washing and sucking the fluid out over and over until the liquid coming out is completely crystal clear.
So they're essentially emptying the toxic blood.
Yes, washing away all that inflammatory fluid. And once the cavity is perfectly clean, they introduce the destroying agent.
The chemical wash.
Right. They inject a highly concentrated 96% ethanol alcohol solution directly into the empty cyst cavity.
Oh, wow. Pure alcohol.
They let that pure alcohol sit inside the cyst for about 10 to 15 minutes to chemically burn away and destroy the endometriosis tissue lining the cyst wall.
Okay.
Then, after the time is up, they suck the alcohol back out.
Okay, I have to stop you there because reading this raised a huge logistical question for me.
Sure.
I'm trying to picture the physics of this in my head, and I'm totally baffled. If you punch a 5-millimeter hole in a cyst and then forcefully inject it with highly concentrated 96% liquid alcohol.
Yeah.
How does the alcohol not just immediately pour back out of that exact same hole and spill toxic ethanol all over the patient's healthy internal organs?
It's like a brilliant mechanical workaround, actually. They don't just use a standard open-ended needle to inject the alcohol.
Oh, they don't?
No, they insert a specialized double-lumen catheter into the cyst, and on the very tip of this catheter is a tiny inflatable balloon.
Okay, tracking.
Once the tip of the catheter is completely inside the cyst cavity, they fill that tiny balloon with 5 milliliters of sterile water. Then the surgeon gently pulls the whole catheter back toward themselves.
Oh, I see it. The water-filled balloon acts like a stopper from the inside.
Exactly.
They're pulling the balloon tight against the inside of the 5 millimeter puncture hole, plugging the exit from the inside out.
It creates a watertight seal. The alcohol goes in through a secondary channel in the catheter, completely trapped by the balloon.
That is incredibly clever.
But there's another layer of fluid dynamics at play here. You might naturally assume they fill the cyst completely to the brim with alcohol to make absolutely sure they touch every single microscopic endometriosis cell on the walls.
Right, wouldn't you want to coat everything?
But they deliberately don't do that. They only inject enough alcohol to fill roughly 60% of the cyst's estimated volume.
Which feels completely counterintuitive until you read their reasoning. The surgeons explicitly noted that trying to refill a biological cyst to 100% of its volume without creating outward pressure and risking a spill is basically impossible in a real-world operating room.
Yeah, it's just too risky.
So instead, filling it to only 60% creates what they call a deflated balloon effect.
If you think about the geometry of it, when you only partially fill a hollow sphere and suck the remaining air out, the walls naturally collapse in on themselves.
Oh.
The internal tissue folds inward. So even though the liquid alcohol only takes up 60% of the available space, the collapsed walls of the cyst are now all touching the liquid.
That makes total sense.
The alcohol coats the entire internal surface area safely, without any outward pressure threatening to pop the balloon seal.
It is such an elegant mechanical solution to a very messy biological problem.
It really is.
But, of course, a clever surgical trick is completely meaningless if it doesn't actually solve the core dilemma we talked about at the beginning. The ultimate test isn't just whether the alcohol destroys the cyst safely without spilling. The real test is whether the biological markers of fertility, that precious ovarian reserve, actually survive the alcohol soak better than they survive being cut out.
And that brings us to the data from the 69 women in the Bordeaux study.
Okay.
Remember, we are measuring success by tracking the anti-müllerian hormone, the AMH levels, through blood tests taken before the surgery and then again after the surgery.
Right. So I'm looking at the numbers here, and I want to see if this actually worked.
Yeah.
The researchers found that the average AMH level before surgery for these patients was 3.4 nanograms per milliliter.
Right.
After the sclerotherapy procedure, the average AMH dropped to 2.0. That is an average drop of 1.3 points.
Yeah.
They also checked something called the antral follicle count, which is essentially an ultrasound count of the resting eggs, and that actually went up slightly, but the study noted the increase wasn't statistically significant.
Right. So we rely mostly on the AMH.
So let's just focus clearly on that AMH drop. Here's where it gets really interesting to me. A drop of 1.3 doesn't sound like a total victory.
It doesn't, no.
If the entire point of this highly complex 10-minute chemical bomb diffusal is to save a woman's fertility, isn't any loss of AMH still a failure of the procedure?
On the surface, if you are just looking at a single number, it might look that way. But medical data requires context. You have to compare this drop to the alternative.
Okay, the surgery to cut it out.
Exactly. To do that, the study references a massive meta-analysis by a researcher named Eunice. Eunice and his team aggregated the historical data from studies looking at the standard treatment physically cutting the cyst out.
What did they find?
According to that vast pool of data, a standard cystectomy results in an estimated AMH drop of 2.13.
Oh, wow. Okay, that puts it into perspective.
Yeah, standard surgery drops your reserve by well over 2 full points. This sclerotherapy drops it by 1.3.
That's a huge difference.
In the incredibly delicate, unforgiving economy of the ovarian reserve, saving nearly a whole point of AMH is a huge victory. It's really about significant harm reduction.
That makes total sense. You are choosing the path that does the least irreversible damage.
Exactly.
But as they dug into the data, the researchers found a very strange paradox regarding who actually lost the most AMH during the procedure.
Yes, and this raises an important point about how biology can surprise us. They crunched the data from every angle.
Right.
They looked to see if factors like the patient's age, their body mass index, or the size of the cyst predicted a bigger drop in AMH after the alcohol wash.
Did any of those matter?
None of those factors mattered. The only factor independently associated with a massive decrease in AMH after surgery was having a very high AMH level before the surgery.
So the more reserve you appeared to have on paper, the more you lost during the procedure?
Yeah.
Why would having more eggs make you lose more eggs?
The study offers two fascinating hypotheses for this. The first is simply that the initial blood test is lying to us.
Wait, lying.
Well, the broader medical literature suggests that very large endometriomas might act as a sort of irritant that artificially inflates AMH levels in the blood.
Oh, interesting.
Because all the patients in this study had cysts over 4 centimeters, their baseline AMH might have been falsely elevated by the sheer presence of the disease itself.
Oh, I see.
When the cyst is destroyed by the alcohol, the AMH drops back down to the patient's true, normal baseline level.
So in that scenario, the drop isn't necessarily a loss of fertility, it's just the correction of a flawed test.
Right. But the second hypothesis is much darker, and it has major implications. It's known in the literature as the burnout theory.
Let's get into this because this concept completely blew my mind when I read it.
Remember that AMH is secreted by the primordial follicles, those microscopic, dormant, immature eggs resting in the healthy ovarian cortex.
Right.
The burnout theory is actually borrowed from in vitro studies done on mice using cytotoxic agents, specifically things like cyclophosphamides, which are used in harsh chemotherapy. The theory suggests that these dormant primordial follicles are incredibly hypersensitive to any sort of toxic stress in their environment.
And sitting near 96% pure ethanol is absolutely a toxic stress event for human cells. I mean, that's why it destroys the cyst tissue so effectively.
Exactly. So the burnout theory suggests that even though the alcohol is safely contained inside the cyst cavity and never actually touches the healthy ovarian cortex, its mere proximity is enough.
Just be nearby.
Yeah. Just having pure alcohol sitting adjacent to the healthy tissue for 10 minutes creates enough of a localized toxic stress event that it causes the most sensitive, dormant primordial follicles to essentially panic.
Wow.
They activate prematurely in response to the stress, burn through their cellular energy, and die.
It's silent collateral damage. The alcohol doesn't touch the healthy cells, but the toxic stress of the chemical neighborhood causes them to essentially short circuit.
And if you start with a higher number of follicles, meaning a higher initial AMH, you simply have a much larger population of sensitive cells susceptible to this toxic burnout. It is a sobering reminder that there is no such thing as a biological free lunch. Even the most careful, perfectly executed intervention has systemic impacts.
So math on a page is great, and theories are fascinating, but we need to talk about what this meant for the actual lives of the women in this study.
Yeah, the real-world results.
AMH numbers are just a proxy for fertility. The real question is, did this procedure allow these patients to achieve their family planning goals? Did anyone actually get pregnant?
The human outcomes are arguably the most compelling part of the entire data set. Out of the 69 patients, 44 explicitly stated an intention to conceive after recovering from the surgery.
Okay.
Of those 44 women, 18 successfully became pregnant. That is a pregnancy rate of about 41%.
That's fantastic. And how did they get pregnant? Because earlier we mentioned that endometriosis often forces people into complex IVF journeys because of the damage to the pelvic environment.
Well, 11 of those 18 pregnancies were achieved through assisted reproductive technology like IVF. But crucially, 7 of those women conceived naturally. The sclerotherapy effectively preserved both pathways to pregnancy.
We also have to look at the recurrence rate.
Yes, very important.
Because if the chemical wash doesn't kill all the endometriosis and the cyst just grows back immediately, then preserving the AMH doesn't really matter. You'll just have to do surgery again and lose more eggs anyway.
Right. Out of 51 patients who had long-term follow-up ultrasounds, 6 of them had a recurrence of an endometrioma over 20 millimeters.
Okay.
That is an 11.8% recurrence rate over an average follow-up of about 17 and a half months.
Okay, 11.8%.
And we must add a very critical caveat to that 11.8% figure. None of those 6 patients were symptomatic.
Really? No pain?
They didn't have pelvic pain. The recurring cysts were only found because the doctors were actively looking for them on routine ultrasounds.
Oh, wow.
When you compare that to the traditional cystectomy, cutting the cyst out, which has recurrence rates generally cited anywhere between 10 and 22%, the sclerotherapy is highly competitive in keeping the disease at bay.
So it effectively treats the disease, it preserves significantly more of the ovarian reserve than cutting, and it allows for pregnancy. It really does seem like a viable alternative.
It absolutely does.
But before we wrap up, I want to highlight a delightfully relatable, almost funny detail hidden deep in the methodology of this paper. I think it says so much about how science actually happens in the real world.
You're talking about the missing blood tests in the post-op data?
Yes, the study started with 69 patients, but if you look closely at the data tables, only 41 of them had complete before and after AMH blood work.
Yeah.
As someone reading the study, my first instinct is always suspicion. I thought, why did nearly 30 patients drop out of the data pool? Did something go terribly wrong? Are they hiding something?
Naturally.
And then the authors casually explain why. The AMH blood test costs €50.
And it was not covered by the French social security system at the time of the study, at least not until April 2021.
Right. So the doctors ask the patients to please go get their post-op blood drawn so they can publish their pristine data.
Yeah.
And the patients who no longer wanted to get pregnant simply said, no thanks, I'm not paying €50 out of pocket just to complete your spreadsheet.
Exactly. It is such a perfect example of real-world messiness.
Totally.
It's a vital lesson in scientific literacy.
Yeah.
When we read a study and see missing data or a shrinking sample size, our minds often jump to a conspiracy or a fatal flaw in the medicine.
Right.
Sometimes the limitation of the science is simply that regular people are budget conscious and don't want to pay for unnecessary lab work. It reminds us to always look at the practical human reasons behind clinical study constraints.
Absolutely. So if you're listening to this and wondering what it means for the landscape of endometriosis care, the takeaway is incredibly clear.
Yeah, it really is.
Laparoscopic sclerotherapy is not just a theoretical experiment. It is a highly viable, real-world alternative to the destructive nature of traditional cystectomies.
By using ethanol to selectively destroy the endometriosis tissue from the inside out, surgeons can preserve significantly more of the healthy ovarian cortex.
It results in less hormone loss, it boasts comparable recurrence rates, and most importantly, it successfully preserves pathways to pregnancy for patients who are navigating the brutal realities of deep infiltrative endometriosis.
It finally gives women a choice that doesn't feel like a punishment. It's a massive step forward in gynecological surgery.
It truly is.
But I want to leave you with the final thought, circling back to that burnout theory we discussed regarding the loss of AMH.
Okay.
We noted that the microscopic primordial follicles in the ovaries appear to be incredibly hypersensitive to toxins.
Right.
So sensitive, in fact, that simply having 96% alcohol sit adjacent to them inside a sealed cyst wall for just 10 minutes can cause a percentage of them to permanently burn out and die.
Just from the pure proximity to the chemical stress.
Right. So if a brief localized exposure to a chemical during a controlled surgery can trigger irreversible follicular death,
Yeah.
what does that imply for the other environmental, chemical, or dietary toxins that women are exposed to every single day?
Oh, wow.
From the microplastics in our drinking water, to the endocrine disruptors hidden in cosmetics, to the heavy preservatives in our food, could everyday low-level chemical exposures be quietly triggering this exact same silent burnout of the ovarian reserve without anyone even noticing until it's too late?